I'm going to walk through some of the pharmacologic but also non-pharmacologic advances that are going on right now in the field of ADHD. We touched on a few of these yesterday during our session, so I'm going to review a few of those, but a lot of these are going to be unique to what you heard yesterday. So we're going to explore the role of therapeutic interventions in ADHD, examine the role of both stimulant and non-stimulant options for ADHD, learn about the emerging role for digital therapeutics, and we're going to develop strategies to improve outcomes in your practice. So my analogy when it comes to ADHD is always that ADHD is a journey. It's a journey through life. It's a journey from childhood to adolescence to adulthood. It's a journey from one day to the next. And as we go through that journey in life, the question is, what's coming around the corner? What's up next? And what we know is for our patients with ADHD, one day may be a good day, but the next day may kind of fall apart. They may forget something. They may lose it emotionally. Their coping strategies aren't working, or they may get distracted and unfortunately have an accident and run off the road. So life is a journey. How do we kind of follow our patients throughout that journey and make sure we're optimizing the outcomes for our patients? This is a slide we talked about yesterday. It just shows the persistence of ADHD. And I'll say in some ways, this is the historical persistence. We know that ADHD around the world is somewhere between 8 to 10% of children. We know for the majority of those children, it's going to persist in some form or another from adolescence to adulthood and even into senior aging. Something we haven't talked much about. How many people in the room are 50 and above? Okay, half. How much do we talk about ADHD in people that are 50 and above? Almost never. So what does ADHD look like towards the end of your career? What does ADHD look like in a woman who's maybe got menopausal changes going on because estrogen changes the way our body binds dopamine? What does ADHD look like as I start thinking about retirement and still having a life that has a sense of purpose? I was talking to one of the families yesterday. Yeah, you go to middle school, you start changing classes. Everything gets more complicated. You go from middle school to high school, and all of a sudden I'm driving, I've got a job, I'm dating. You go off to college, you're living independently. You go into adulthood, you've got ADHD, and now I'm managing my kids' lives on top of everything else. So as Dr. Goodman talked about yesterday, now all of a sudden I have to have coping strategies not just for me, but for my family unit. So how does life and ADHD affect those transitions as we go through it? This is a slide that we talked about, I believe, yesterday, but I'm going to walk you through the data sets. On the right-hand side is an older historic study done here in the United States where they said, how does IQ affect ADHD? And the first take-home is ADHD doesn't discriminate. You can have ADHD at the low end of the IQ span. I take care of a lot of kids with developmental disabilities, learning disabilities, autism spectrum who become adults that have those conditions. ADHD can be right in the middle of the IQ span. You know, somebody who's in the average but is distractible, forgetful, has difficulties with time management organization. And then the secret is ADHD can be at the upper end of the IQ span. I take care of doctors, lawyers, teachers, professors who have pretty severe ADHD, but they've been bright enough that early in life they could compensate, and now the wheels are coming off the bus. So ADHD does not discriminate by IQ, but IQ does change when ADHD gets diagnosed. If you look at this study, what are we looking at? Is the age of initial diagnosis based on your IQ. So if you take a look and say, if I have 100 IQ, what's the average age of diagnosis if I look at this graph? It's age 8, 9, 10. The average kid with ADHD, 100 IQ, average age of diagnosis, 8, 9, 10. What happens if I have 120, 130 IQ? I have enough reserves that I compensate when I'm younger. But eventually I hit my ceiling. So if you're one of those brighter people, you're a nurse who goes back for your advanced practice training and now you're trying to manage your own home life, maybe you've always had a little distractibility, you've always had some time management issues, it's always been there, but it never caused impairment until you tap those reserves. So not uncommon, a lot of people say, listen, I've always been wired this way, but God, now that I'm a parent and I got to organize my kids and my own life, I have to have a relationship with somebody else in my life, now the wheels are falling off the bus. The study on the left is a separate study. This was done in South America by the current president of the World Federation of ADHD, Luis Rode. And he said, listen, we followed these kids from childhood into adulthood. Who are the people most likely to have gotten missed as kids, or we didn't pick it up as kids even though we were looking? But now as adults, they're meeting criteria for ADHD. And what did he find? Number one, women. Women were more likely to get missed. Maybe they didn't have the outward hyperactive marker. Maybe they didn't have impairment, but women more likely than men. Higher IQ, just as we saw in the study on the right. And then the more years of education. If you keep going on with your education and you have ADHD, eventually you tend to hit a ceiling. Things get more complicated. That kid that goes from grade school to middle school gets more complicated. Middle school to high school, more life commitments. High school to college, even more commitments. So you think about those things as far as how people present. So our take home is IQ helps you to compensate at first, but eventually people tend to hit a ceiling. So eventually people tend to hit a ceiling. This is a really interesting study. It's a different study. This would be like a Vlad Maletic study that, Vlad was showing us this crazy bright stuff earlier. This said, let's take a look at the genetic linkages of ADHD with other health conditions. Large study. Millions of patients. And what you see is when you look at it, what's the #1 genetic linkage with ADHD? It's up in your top left corner. It's not depression, it's not anxiety, those are linked. What's the #1 linkage? BMI, body mass index. Here's a secret we don't talk much about. If you follow adults into adulthood with ADHD, what starts happening over time? They eat impulsively, they don't modulate their appetite, BMI starts going up, and those two conditions are highly cross-linked. If you're impulsive and you do things impulsively, it doesn't just affect things up here, it affects things down there. So when you talk about the primary care kind of burden of ADHD, BMI, one of the highest genetic linkage, we see cognitive abilities, we see impulse control when it comes to substance use, we see mood disorders, anxiety. Look over on the right-hand side then is a different study, or a different take on the study, same study, but we're going to look at individual personality traits. What are the personality traits that are the most genetically linked with ADHD? Mood swings, low self-esteem, loneliness, irritability. Highly genetically linked. And if you look at the significance, a P of 0.00000 and what it goes out to like 14 O's. That's how highly correlated those individual personality traits are with ADHD. So why is it not uncommon that we see somebody with ADHD who says, listen, I'm good on a good day, but on a frustrating day, I tend to blow up. I'm good on a good day, but on a tough day, I tend to get overwhelmed. I tend to feel lonely. I tend to feel isolated, even though I know I shouldn't, but I do. And it's impulsive, and then it kind of goes away because those things are highly genetically linked, those traits together. If we look at this study, this is a study I think we saw maybe yesterday, but it's a college-age study that says, listen, let's take a look at some of the comorbidities in a college-age population. We're sending these kids off to live on their own. They're trying to be independent. This is an important, critical time when you think about development. What we see here is ADHD doesn't run alone. ADHD in our college students tends to be highly comorbid with depression, anxiety, unfortunately, trauma. If you're a woman with ADHD, you maybe don't choose a good mate. Maybe you expose yourself to things in dating situations. So PTSD and trauma highly significantly elevated in our college students with ADHD. This is a study that came out a few years ago, and it said, okay, why do people with ADHD have higher mortality rates? And they do. We've seen data on this. Mortality rates with ADHD are anywhere from 50% higher up to 800% higher than the general population, depending on which study you look at. This study said, okay, we knew it's things like accidental injury, a driving accident, maybe stepping into traffic and not looking to see if the car's coming down the road. Those kind of things happen with ADHD, we knew it. But this study came back and they said, okay, what are the other increased risk factors for mortality with ADHD? And I've highlighted two of them. Unfortunately, suicide. If you have ADHD, you're demoralized, maybe you're dabbling in drugs and alcohol, maybe you've developed comorbid depression, maybe you've just had a relationship blow up. Suicide significantly increased, about 3 times higher in our patients with ADHD versus non-ADHD. So make sure you help them to develop what's your strategy, what's your support network, what's your crisis intervention if you start feeling overwhelmed after something happens. Who do you call? Where do you call? What's our crisis intervention hotline in St. Louis that you can call and get somebody that you can talk to for free? The next one I highlighted down there, and it goes back with something we saw in our college-age students. Women with ADHD are 3 times more likely to die as a victim of homicide. 3 times. They're more likely to die as a victim of domestic violence. Why? And you go back to your adverse childhood events, okay, the abstract you just showed us. If you have ADHD and you don't feel good about yourself, maybe you wander into a bad peer group. If you have ADHD and you're dabbling in drugs and alcohol, you tend to be dabbling with other people that are doing drugs and alcohol, so things get volatile. If you have ADHD, perhaps you don't put up with a good mate, and you put up with somebody who doesn't treat you the way they should. So when we talk about the importance of early intervention, recognizing ADHD, talking about the outcomes of ADHD, the holistic nature of what we're going to do to move the needle, these are some of the important data sets. It's not just a set of symptoms. It's not just studying and being able to study a little more. It's how does ADHD affect you in your daily life? This was another really important study that said as ADHD goes along, we start building more comorbidities. The longer you go without treatment, the longer you go without diagnosis, the more comorbid and complicated ADHD tends to become. We see that if you have ADHD by itself, no other health conditions, mental health conditions, 50% higher mortality rate. What happens is we stack other comorbidities. If you have ADHD plus one other comorbidity, depression, anxiety, insomnia, mortality rates now are 4 times the general population. What happens if I give you 2 comorbidities? A woman maybe has gotten anxiety and now she's gotten demoralized, she has depression as well. ADHD mortality rate is 8 times the general population. So simple ADHD becomes complicated ADHD, it becomes comorbid ADHD, which becomes lethal ADHD. When we talk to our primary care friends, they'll say, you're just treating everybody. I said, no. We don't want to overtreat anybody, but we also don't want to miss anybody. This would be like somebody walking around with cardiovascular risk factors and you didn't pick it up. Simple ADHD becomes complicated ADHD, which dramatically increases mortality rates over time. This is one of our take-home ARS questions. So ARS question number 1. Pay attention out there in the audience. Pay attention here in Chicago. If you have somebody that has bipolar disorder or schizoaffective disorder, and they also have ADHD, it was a big data set. They screened, out of this big group of patients, 19% of people with bipolar disorder also met criteria for ADHD. That's the number you'll typically see. It's about 1 in 5. Truly have ADHD if you look for it. And the question is, does it make sense to treat ADHD, or, hey, is that terrible? It's going to destabilize their bipolar disorder if I start giving them ADHD treatments. So in this study, they said, let's take a look, and let's take a look in particular at these patients who are having self-injurious behavior, suicide attempts. Does treating their ADHD make a difference there? So what did we see? Self-injurious behavior, non-suicidal behavior, but self-injurious, dramatically decreased when we treated their ADHD along with treating their bipolar disorder. Holistic treatment of both. Numbers of suicide events were decreased quite a bit. Hospitalizations decreased from 31 to 19. So we cut that number down by about 40%, not 70%. But we did see reductions. The odds ratios were 0.63, so 60% the ratio of doing it if you weren't receiving ADHD treatment. So take-home treatment, holistic treatment of people that have ADHD plus bipolar disorder or bipolar spectrum. Holistic treatment of both conditions tends to actually stabilize outcomes, decrease impulsivity, and impulsivity leads to suicide attempts. So those 2 things together, when done correctly, actually move the needle. This is another really important take-home study, and it's an important study because it goes across all of ADHD treatment. It's the importance of staying consistent with your treatment. What are the old myths of ADHD treatment? And I'll ask the audience, I know when I was going through residency at WashU, we didn't get a lot of lectures about ADHD to begin with, but the lectures we did get were take your treatments when you need them. So if you're studying, you're at work, you've got something important coming up, then take your treatments. But don't take these medicines on the weekends, holidays. Give yourself medication holidays. Only take them when you need them. This is a study that will fly in the face of that, and all of our studies really fly in the face of that. This is a study over 2 years of adults that had ADHD. And in this study, I'm going to follow you versus you, not you versus somebody else. So I'm going to follow you when you're driving a car or operating a motor vehicle in the months that you took your medicine versus the months you thought, hey, I'll give it a medication holiday. And maybe that medication holiday is over the summer, maybe it's over Christmas break. So these are adults with ADHD, and I'm going to track you versus you over 2-year periods. What did we find? Women with ADHD, in the months that they didn't take their medicine, had a 27% increased rate of motor vehicle trauma rates. 27% in the months they thought they didn't need their medicine or didn't refill it. 27%. How about men with ADHD? 34% increased trauma rate. I'm distracted, I'm impulsive, maybe I'm rushing. 34% increased trauma rates in the months I didn't take my medicine. And how about your most impulsive ADHD patients? Your patient who likes to ride motorcycles, jet skis, snowmobiles. The months they didn't take their medicine, their trauma rate was 50% higher. You cut trauma rates in half by being consistent with your treatment. So what's the message? Holistic treatment, ongoing treatment. Find the right treatment that gives the best outcome for you, but be consistent with it. Because ADHD doesn't take a vacation. This just looks at various aspects of ADHD treatment. In orange is where we move the needle, and blue is, okay, it doesn't move the needle quite as much, but you see across many life outcomes, ADHD treatment moves the needle. It moves the needle in driving, we talked about it. It moves the needle in obesity. If you're trying to modulate your appetite and trying to lose weight and exercise, you're better if you stay on treatment. Any internist will tell you that when they're dealing with somebody with type 2 diabetes plus ADHD. We talk about self-esteem. Look at the self-esteem differences. Relationship differences. Staying consistent in a marriage. Being a better parent. Okay, who should you screen? Tim Bilkey, a good friend of mine up in Toronto, has a book called Fast Minds. It's dedicated to a lot of his patients with ADHD, and he came up with a moniker that I love. And his moniker is PDF. In this digital world, we all know what a PDF is, right? You open it up, it's got all this data, you store it, you download it, whatever. What's the PDF of ADHD in the digital world? The PDF is procrastination, distractibility, forgetfulness. If you see those things running together with a patient, screen for ADHD. I'm going to ask you to try to screen everybody, no matter who walks in your door, but if you see that, PDF, think about adult ADHD. Do you procrastinate? Procrastination is the devil. It's the devil for college students. I put things off, then I get overwhelmed, then I get anxiety, then everything blows up, distractibility, forgetfulness. Family history of ADHD, remember, highly genetic, 75% heritability. If they've had treatment-resistant depression, MDD, bipolar, look to see if there's not ADHD underneath it that's causing them to be more resistant to treatment. If they've had drug abuse, if they had poor school performance, motor vehicle issues, forgetfulness. Dr. Goodman made the kind of joke, but it's true. Ask your secretaries who in your practice has ADHD. They'll know it. Why? This person shows up late for the appointment. You love them, but they show up late over and over again. They forget to bring their checkbook. They don't have their credit card. You know, all of those types of things, but forgetfulness, it's one of the hallmarks we see. Okay, I'm going to give you a patient. Catherine's a mother of 2, presents with chief complaints, being stressed, behind on her bills, took an SSRI for 3 years. You know, said, I think it helped some. PHQ-9 is a 12. No suicidal ideation. GAD-7 is a 13. MDQ, screening for bipolarity, is a 4. Under 7 means probably not bipolar. I get so overwhelmed I just feel like giving up. She asked for something for help with anxiety. What do you do next? So when we talk about it, mom had anxiety, dad was a drinker, 6-year-old son's a handful. We get a lot of calls from school. She did well in grade school, very social, but got a little bored in high school, got frustrated, dropped out of college. So we give her our screening scale. Our screening scale, and we've talked about this before, our mental health vitals. When we look at our mental health vitals, what do we see? GAD-7, 13, PHQ-9, 12, MDQ, 4. When we give her that screening scale for ADHD, and what did we hear from Dr. Goodman yesterday? How long does it take to do this screening scale? 20 seconds. 20 seconds was his estimate. If you look at it, it's 6 items. The patient fills it out. Boom, 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 boom. Which of these have you had? If you got 4 or more of these, sensitivity, specificity of having ADHD, 90+%. It doesn't make the diagnosis, but it's a great screening scale to say, could there possibly be it? You then give them the longer version. In the longer version, all 18 items, the score comes in at a 37. Anything in the 30s and 40s means you've got moderate to even mildly severe ADHD. This is somebody who's having impairment. When we treat them, people come in, their scores in the 30s and 40s. Well, partial treatment will be down a little bit lower. We want to get scores down to where they're mild or less on average on these scales. So I don't care which scale you use, the ACERS, the ADHD-RS, I want all 18 symptoms to be mild or less on average. Okay, and you can even do a little better than that. A lot of the studies Ann and I have been a part of, by the end of the study, people's scores are a 14. So that's kind of in the ballpark of where you should go with treatment. This is a study that I think I referenced yesterday, but we didn't show. This looked at kids. It's one of the few studies that said, listen, I'm going to give kids with ADHD, everybody gets a methylphenidate, everybody gets an amphetamine. And let's see if you do better with one or the other. What do we see in the middle? 41% did pretty well with either a methylphenidate or an amphetamine. We see 28% did better with an amphetamine. We see 16% did better with a methylphenidate. And you see 13% down below that neither stimulant worked very well. Maybe due to side effects. Maybe it caused tics, anxiety, weight loss. So what's it mean in your toolbox? You're going to have a couple of methylphenidates. Some people do better. You're going to have a couple of amphetamines you get to know. And you're going to have a couple of non-stimulants you get to know. Because 13% of people aren't going to do well with either stimulant. So you have to have those kind of tools in your toolbox. We saw this yesterday, our list of medicines. We have 32 different stimulant preparations. We have 4 non-stimulants. Our big take-home here is short-acting stimulants actually don't have specific FDA indications for adults. The only medicines that have specific FDA indications for adults is long-acting stimulants and now 2 non-stimulants. Short-acting stimulants are the trap. I tried a little bit of this from my roommate. I really liked it. And if it's a short-acting stimulant, beware. You've already got signs the person's probably misusing medicines. They may be liking it for the wrong reasons. So step back, make a diagnosis, see what's going on, but use the medicines that are FDA approved when it comes to adult ADHD. This is a meta-analysis by one of our friends over in the United Kingdom, and he said, which ADHD medicines work? And the answer is they all work. Somebody asked me a question yesterday about bupropion, whoever it was, and we see that bupropion works. The effect size not quite as high as some of the other compounds there. So we tend to think about stimulants being first-line treatments, non-stimulants kind of being the next line of treatment, and then we talk about the off-label treatments, things like modafinil, bupropion, things of that nature. This is an interesting study that said, how does prescription use change over time? In kids, what we tend to find is that most of the kids are methylphenidate and gray. You'll have more kids on methylphenidates. Pediatricians will tell you this. Maybe a little milder, maybe it's just habit, but more kids will be on methylphenidate than amphetamine. As you go to adults, it's just the opposite. 80% will be on amphetamine, 20% on methylphenidate. It may be the mechanism of action. Amphetamines have multiple ways to raise dopamine and norepinephrine. What's the cross point where it's about a 50-50 world? It's teenage. 13 to 15 prescriptions are about 50-50 if you look at it. More methylphenidates in kids, more amphetamines in adults. You're still going to need both. And that crosstalk, as they start having more developmental demands, some people will shift from methylphenidates to amphetamines. This is our list we saw before. It's a take-home reference. It talks about onset and offset. How quick does a medicine get in your system? How long does it last? Is it sprinkleable? Is it chewable? Is it dissolvable? Same thing when it comes from amphetamines. This is an article that Dr. Young and I put together a few years ago. And here's your non-stimulant options. FDA-approved medicines. This is a partial list at this point. We've had some other ones come out since then. The take-home is it's long-acting stimulants, once-daily medicines, plus 2 non-stimulants when we think about what's approved for adults. How about the new kids on the block? So the next handful of minutes, I'm going to walk through some of the new interventions. The first one is a prodrug methylphenidate. It was one of our take-home ARS questions, I believe. And so in this case, we've had a prodrug amphetamine for years. It's been pretty popular. I like using it quite a bit, lisdexamphetamine. We haven't had a prodrug methylphenidate. So in this case, we have a methylphenidate, demethylphenidate that's bound to niacin, a B vitamin, and serine, an amino acid we all have. When you bind those things together, it creates a stable bond that won't cross the blood-brain barrier. So it has to be metabolized in your body to pull the niacin off, to pull the serine off, and then the demethylphenidate can cross the blood-brain barrier. So that's serdexmethylphenidate. It's a methylphenidate prodrug. It has to be activated in your body. You have to metabolize it for it to cross the blood-brain barrier. A lot of us like these kind of prodrug combinations because in general, they tend to be smooth on and smooth off in our patients. They don't get in quickly. There's not a robust kind of onset offset. And in this case, they coupled it with 30% short-acting demethylphenidate. And the theory was we're going to use this prodrug that gets in slowly to capture the day. We'll use a little demethylphenidate to capture the morning. We'll combine them together in a 70-30 combination. So Serdex got something we've never had before. It's the first ADHD stimulant to get a C4 designation by the FDA. Instead of C2, where every other stimulant is, it got a C4. And why? Because in abuse studies, it was less abusable than short-acting stimulant. it was less abusable than phentermine, which is C4 for weight loss. So it had lower abuse potential, both orally and IV, so it's the first ADHD stimulant to be C4. Now it's in combination with 30% short-acting dimethylphenate. So the combination together is still C2, but 70% of it has now been designated as a C4 medication. 3 different doses that combine 70-30, the prodrug plus the short-acting methylphenidate. The starting dose in the study was the middle dose. They didn't start low and work their way up. They said, we think the smoothness of this, we can start right with the middle dose. And over time, what did we see with ADHD scores? They started at 41. What's the goal I said we wanted to get to? Under 18, and really the lower the better. So here we're getting down to a 12. All 18 items are mild or less on average. With long-term treatment, this combination was able to achieve, pretty robust long-term efficacy. Combinations were all the things you'd think about as far as side effects, will decrease appetite. Sleep actually improved over time for a lot of our patients. The average person has a slight benefit in sleep. I'm working on an article right now with Dr. Childress on this. We've got a new transdermal D-amphetamine patch. So it's a patch you can wear. It's a Band-Aid for your medicine. So the wear time you're supposed to do is 9 hours. You put it on, you wear it for 9 hours. What we see when we look at this is we see benefit and improvement in symptoms up to about 12 hours with overall benefit. So we see that 9-hour wear time gets me excretion of this medicine over about 12 hours. This is an article I'm working on right now with Steve Ferrone that said, how about kids that don't want to wear it 9 hours? I wake up at noon. I'm a teenager. I don't want a 12-hour medicine. That'd be midnight, right? So how about a medicine that we can change the duration by how long we wear it? Because all of our other long-acting medicines, they're going to last as long as they're going to last, right? If I take a 12-hour medicine, when I take it, it's going to last 12 hours. So in this study, we looked at in those middle weeks, how about a kid that just wears it for 2 hours? What happens to blood levels? You get therapeutic blood levels with shorter periods of time. What happens if I want to wear it for 4 hours? I need to study till 8 or 10 o'clock. You can do that. So it'll give the option of flexibility of wear time to give you flexibility of duration and minimize some of the use of having to have short-acting stimulants. Very similar kind of side effects to what we're used to seeing with a stimulant, and very few dropouts due to patch effects. The next one is one we talked about yesterday. It's viloxazine. Just got the adult indication. We see in the prefrontal cortex we're increasing serotonin, norepinephrine, and dopamine. The interesting part is raising serotonin. We don't have many, if any, ADHD treatments right now that do that. And down in the nucleus accumbens, where we see addiction potential, we don't hit dopamine, which is why it's a non-scheduled medicine. We didn't see signs of abuse potential. It improved in the adult study that just came out, the data. We were a part of this study. It improved ADHD symptoms within 2 weeks, continued to improve over the course of the study. We saw equal improvement when we look at inattentive and impulsive symptoms. This is an interesting take, and I think Dr. Childress worked on this. We said, how about executive function? Executive function is planning for tomorrow, my strategies. Executive function is planning for today, time management. As we improved ADHD symptoms, we did a direct improvement of executive function with this compound. So not just ADHD symptoms, but executive function, planning, organization. We were able to show significant improvements with this non-stimulant compound over time. This is the long-term data we talked about, I believe, yesterday, that in the short term but the long term, continue to see efficacy with long-term benefit. The side effects, the most common for adults was insomnia. Kids, it was sedation. With adults, it was insomnia. Then we see somnolence and we see fatigue. In general, these were mild and well tolerated. Digital interventions. There's a number of digital interventions right now looking at depression, ADHD, being compliant with my medicine, reminders, sleep digital coaching apps that improve insomnia. The VA has a big program of digital interventions for vets with insomnia that work pretty well. In this case, we're going to talk about one that just got FDA approved. It got FDA approved for kids with ADHD. It's a digital video game you play that stretches working memory and concentration. And over time, with doing this consistently, it gets harder and harder and harder, so it makes you focus longer and not get distracted. It makes you tired when you do it, but it's fun. It's got a lot of stimulus, but you're stretching working memory. You're stretching processing speed. And in the pediatric ADHD study, it was shown to improve concentration on this objective measure called the TOVA. So it improved working memory there. If you're an adult, do you want to play these video games and keep your mind sharper? They have tens of billions of games that have been played by hundreds of millions of adults, and they can measure which of these games improved in people with different health conditions. because they have their health status. So if you have depression, ADHD, chronic pain, which of these working memory and cognition things improved as you did them? And now they're having digital tools where they're going to come in and study this set of batteries for people with ADHD. If you're an adult with ADHD and you do these things, can you improve processing speed? Can you improve working memory? What we don't know is, do they work on top of medications? That's just now being explored. We actually had an oral abstract next door talking about it. Do they work in kids and adults? Do they work in people that have comorbidity, autism spectrum? There's some studies going on with post-COVID cognition, depression plus cognitive issues. Where do they work? And do they move the needle in core symptoms, or do they just help with processing speed and working memory? And we'll have to see. There's a lot of studies looking at those. It's really an exciting area, though, to say, listen, if I exercise the brain, can I stretch the brain? So very, very cool studies as we go through it. Stimulant misuse. You know, college students do bad things sometimes with stimulants. We know it. And what we see is when they misuse it, they don't usually misuse it by themselves. The most common way to misuse a stimulant was in combination with other things they shouldn't be doing. Popping a stimulant, using a short-acting stimulant typically, to go out and drink too much. You don't fall asleep because the stimulant keeps you awake, so you increase your risk of alcohol poisoning because you continue to consume alcohol when your body would normally say, fall asleep, get rid of it. So polysubstance abuse is the most common thing to think about when you think about this pattern. So our clinical pearls: try to avoid short-acting stimulants, especially in your adults and your college students. Avoid them, keep them out of harm's way whenever possible. Barriers to screening: you don't see what you don't look for, stigma and embarrassment, normalization, comorbidity, and then don't just treat the chief complaint. Somebody comes in stressed, my patient I gave you, what's causing you to be stressed? Well, I can't meet my deadlines. Why? Because I can't focus, I get distracted. Why? I don't know, I've kind of always been this way. Go back and take a history, walk through it, and then use your mental health vital statistics to sort out what's going on. So let me thank you all at this point.